right. Paula has a smiley. Paula does have a smiley. A winking face. All right, in the interest of time, let's go ahead and get started. Thank you guys so much for coming to our session. So we're going to be presenting our Family Presence Facilitator curriculum for pediatric medical resuscitations. That's how it was designed, but we are in the process of expanding to adult resuscitations as well. Here is a list of the people who are participating. The four of us are here. Paula, Steph, and Kimmy unfortunately couldn't be here, but they're with us in spirit and in this curriculum. We have no conflicts of interest and no disclosures. We did receive grant funding for our standardized participants from our premier group at NYU. So just to start with a little bit of a trigger warning, we all recognize that this curriculum discusses very challenging situations. Emotionally, providing care to a child or really any patient who's critically ill or dying is sensitive. So if you have any, you're feeling like you need to step out, that is totally fine. And as always, if you have any feedback after the session, that would be wonderful. So we're going to start with some goals and objectives and background for the curriculum. We'll go through the curriculum and then summary and leave a couple minutes hopefully for questions at the end. So in terms of goals and objectives, the goal of this curriculum is really to empower every single member of the healthcare team to serve as the Family Presence Facilitator, or the FPF, during pediatric resuscitations. Again, this was designed for pediatric medical resuscitations, but its applicability is really beyond that as well, and we hope to show you that during this session. By the end, you should be able to articulate the purpose and benefits of an FPF and list the main components of the role. So just in terms of some background, we'll go over this relatively quickly. So the Family Presence Facilitator, again, is a designated staff member who provides emotional support for patients and families during pediatric resuscitations. And this should really be someone that's assigned by the team leader. Just as they're assigning the airway person and the primary survey, they're assigning this person to speak with the family during these resuscitations. This is really important. We know that the ACGME and JCO really emphasize patient and family-centered communication, but it requires practice, I think, as anyone who has interacted with a patient and family member during a resuscitation can attest. There's significant heterogeneity in the literature in terms of healthcare provider acceptance. Rates of acceptance vary from 35 to 85%, so there's a wide spread, and there really are limited recommendations for practice and policy. But family members uniformly want to be offered the chance to be present. Throughout the PowerPoint, you'll see quotes from our focus groups with patients and family members interspersed that just speak to the main components of the curriculum and the importance. So in terms of our curriculum development, I'm not going to belabor this, but we started with problem identification, conducted a literature review, and really identified a dearth of curricula similar to this. We conducted targeted needs assessment, including, as I said, focus groups with patients, with family and youth advisory council members, developed our curriculum, and then we've begun disseminating it both within our institution as well as at this conference and at PAS a couple weeks ago. So now we're going to go into the key components of the FPF role. I'm going to turn this over to Joanne Agnant to lead us through respect and value.
Excuse me, sorry. So the first component is respect and value. The first part of it is role assignment and availability. As Ellen mentioned, the Family Presence Facilitator should be a person that is assigned that role by the team leader. Although it is their primary role to support the family, we do understand that there are some institutions you might not have that extra person to do it, and they might have some small role in the resuscitation. It's really important, though, that when they step away from the family to do whatever they need to, that they go back to the family or the patient to continue to support them. Introductions is also very important. We want the Family Presence Facilitator to introduce themselves to the family as well as their role, and then identify key team members, including the team leader and potential other key people taking care of their patient. During the focus groups, there's a question as to how to interact with the family and call them. It's really important to get their preference to what they want to be called. This quote here is for pediatric resuscitation, where family members actually did say that they were okay being called mom or dad because it really highlighted their importance or their role in the patient's life. But what this just kind of signifies is that it's really important just to get the preference of the family and address them how they would prefer to be called. Positioning is the next part of respect and value. So, there's a choice as to whether the family should be within or outside of the room. So the recommendation is to ask them what their preference is, and give them permission to step out, because some family members feel like they should want to be in there, but it could be difficult. Positioning within the room is important. And really dynamic, like should they be within eyesight if that's desired? That might provide some comfort to the patient that's being cared for. Facilitate physical touch when it is possible, and essentially just kind of get an idea from the family whether or not you need to kind of move so that they don't interfere with the care of the patient. Empathetic, culturally competent care is also very important. It's important to acknowledge expressed emotions from the family. So something like, I hear you saying that you are scared, and not projecting what you think. I think that this is scary for you. And it's really important that you essentially follow their lead and interact with them based on what they're telling you, and facilitate linguistic and cultural needs as necessary. And then finally, the next part of respect and value is emotional self-regulation. This is crucial to maintain empathetic, non-judgmental communication. So it's really important to kind of take your own pulse and see how you're feeling, so you're not projecting that on the family, as I mentioned. If you are someone that when you get stressed, you need a lot of information, it's really important that you don't put that on the family and give them more than they would potentially want. And it's okay to be silent, and sometimes it's often necessary. Sometimes we speak just to fill the void, and that's not always to their benefit. Pass on.
Okay, we're going to talk a little bit about information sharing. So, every patient, every family is going to be different in their level of understanding medicine and how they want to be communicated to. So it's really important for you to kind of elicit and use your nonverbal cues on what you think the family would want, and you can even elicit and ask them. So you can kind of ask them, how much detail they're really interested in. So something along the lines of, I can give you details if that's helpful to you. And then also remember, as we're all aware, to try not to use complex medical jargon and use, kind of plain terms. So the next thing that's really important to families is that we're sticking to exactly what we're seeing and we're hearing, and we're not speculating. And so, a lot of this, curriculum, as we mentioned, is primarily for pediatrics and being moved into the adult realm, but it's important not only to just address the family members, but also address the patient themselves, even no matter what their age is, right? So, letting them know there's going to be a piece of plastic put in their nose, and they're going to feel the air, and that's going to help them breathe, and just giving them kind of a sense of what they're going to see, hear, and feel to make them more comfortable and the family more comfortable as well. Non-speculative communication. So we like to use the heart-head-heart model when talking about this. So, I'm sure you've all experienced a family member who is, panicking, of course, and upset, asking, will they survive? And so what you can do in these situations, which is really hard, and if you're unsure how to address that, if you stick to this model of just kind of repeating what you're hearing from them, I hear your concern for your child or family member, then you kind of use your head and what you know is going on. Right now, they've secured a breathing tube, the heart rate is normal and strong, and then go back to heart, I'm here for you in this difficult time with whatever you need. So kind of just always knowing you have something to fall back to, and say to the family member, and this is still extremely supportive without giving them, false hope or, any kind of answer that could be incorrect. And then also remember that these are a lot of resuscitation, there's a lot of people, so be careful, pay attention to privacy, no matter what the age of the patient, and the family members might find this important for their patient as well. And there's probably a lot of times more than just a mom and a dad involved. There could be other people, there could be a babysitter, there could be, a friend who is in the car, so just make sure you're asking who is appropriate to update and who they would like for you to speak with. And that doesn't necessarily need to happen in the room in that moment, but it's just something to always include. And then, lastly, we talk a little bit about de-escalation. So I'm sure you've seen a family member get, very upset and worked up over what's going on, and everyone kind of expresses their grief and concern in different ways. And so there's many different methods that you can use to try to de-escalate. This is one that, we kind of refer to here, recognizing what they're feeling. Once again, that's something you can always go back to and use, and express to them, in a way why this is not going to help the care of their loved one. So you can kind of bring them on board to the same team as you. Like, I want you to help us help your family member. And you can give them, again, another offer to say, why don't we take a few steps back, or why don't we have a seat for a minute, or why don't we get a glass of water, or step out for a moment, and then we can return so that we can take care of your family member best. And then implicit bias. So, we all have had our own life experiences, and everyone has seen people, grieve in different ways, and just recognizing our own bias in that, and that, some people will need to, and we kind of talk about these examples when we've presented this, some people will need to go out and scream into a pillow, or go out and, punch a wall. And we've heard anecdotes from people we presented to of experiences where they go and they find like a safe cushioned space to have a family member kind of hit the wall. And if that's what they need to facilitate their grief, then that's okay too, and you can think outside of the box.
Thanks, Danny. Before I talk about nonverbal communication, I'm just curious, from the 6 or 7 people in the room that I don't know personally, who sees children regularly in the ER versus the children? Yeah, great. And then for the folks who are also seeing adults, who has families present in the room during adult resuscitations? Yeah, great. And then I'm assuming for the peds resuscitations, it's standard practice. Is that, yeah. So I think, we, just to sort of frame, like big picture frame, as Dr. Duncan mentioned, the purpose of this was, I think in peds, it's, pretty much universal standard of practice. There just wasn't a way to teach it. And I think in the adult world, it's becoming increasingly standard of care, but the methods aren't always there unless you have a child life specialist or a social worker or a chaplain. And our goal was really to, empower our medical students, can take this role on very easily. Residents, particularly those who might not have the skill set to participate in other medical skills of the resuscitation. Nurses, oftentimes a code brings a lot of nurses in, and you guys are getting the Reader's Digest version of the curriculum. It's really like an hour to an hour and a half workshop that we typically do, where we go through each of these skills, practice using simulation, and have some, video methods too. And we're hoping eventually to have the full curriculum ready so that everyone, here can bring it to their own institutions as well. So I just wanted to, get a little bit of the background and frame it. Before going on to talking about what we teach in nonverbal communication, which we honestly found is one of the more challenging elements of the curriculum, because as we all know, things that have to do with your phenotype or your countenance can be very gendered and rife with implicit biases. And so how do you tell someone to look nice, right, to the family? And so we really tried to bring the skills that we teach and the way we assess the role down to observable behaviors. So we talk about receptive listening. That means, joint attention. When the family points away a certain way or looks somewhere, you follow their attention to that place. We talk about mirroring body language and mirroring gestures. So if they have open posture, you have open posture. If they, step towards you, you step towards them. We talk a little bit about eye contact and sitting down at eye level, about, sort of open face, which again, what does that mean? It's kind of relaxing your facial muscles, being receptive to the way that someone is speaking to you. So really try and root that in observable behaviors and skills. Physical distance and touch is also challenging because it's very culturally rooted. What we found in our focus groups was that again, limited by the selection bias of our focus groups, not representing every culture or religion, on the planet, that in general, there was great support for just a hand on the shoulder, a hand on the back of the shoulder. So kind of a safe space to touch as a sign of physical support and comfort. But obviously, that also has to be read by certain cues and body language that might not be appropriate in all situations. And then lastly, being in the FPF role, being able to offer some elements of comfort. Would you like a chair? Can I bring you tissues? Would you like to step out for a glass of water? Would you like some ice? These are things that hopefully, most of us who have strong EI skills can anticipate, but as part of the curriculum sometimes does need to be taught and made explicit to folks who are going to take on this role who are not trained in the psychosocial services. And then the last part is the summary and follow-up. So, you imagine you're in the resuscitation, there's a designated person, ideally it's your child life specialist or your social worker, but when it's 2 a.m. in the morning, maybe it's your medical student or your resident, they might not be in the space to provide a medical summary. So one of the elements of serving as the FPF is being the bridge to communicate between the team leader and the family. So when the resuscitation is concluded, to be able to go up to the team leader and say, are you ready to come summarize for the family? So they could come and give that big picture summary about what happened and what the next steps are, transfer to the ICU, whatever it may be. And I have to say that, when we first developed this curriculum, we didn't really explore in the case of patient death because the curriculum was designed to practice during simulations, and most of our simulations don't end in death for our learners. And so this wasn't entrenched in our focus group questions. But in sort of our ad hoc, our post hoc discussions on it, we did think about how all of the mnemonics and teachings out there for how to communicate death to families are based on the assumption that that conversation is happening after the fact and the family hasn't been there with you. There really isn't a model out there of how to experience death together. We think that this is an area ripe for future research, but what we all know from, I think, our collective experience is that if you're the team leader and the family member is there with you, there are some best practices that we've all witnessed: soliciting team suggestions, ideas, and thoughts. Ultrasounding for cardiac standstill, which I know is controversial, and what is the definition of standstill? But what we do know is it helps providers feel more confident in making that call. There isn't great data on how it's perceived by family members, but I think we all have witnessed and felt that that sort of objective corollary might help them ease the grief process and accept death as well, experientially. Also an area of great research for the future. Having a moment of silence after you call it, so both the family and the team can honor the patient together and have a moment of grief together. And then, based on the case requirements, whether you think it's going to be an ME case or not, allowing the family to go to the bedside and touch the patient. If it's a child, hold the patient, right, and have that sort of physical touch after the moment of death. And then, that conversation that we typically have learned in models such as spikes or grieving, the sort of communicating bad news models, there still has to be a sit down afterwards. Just because the family experienced that with you, they're not in a space to fully process everything. And so once the family has a moment to grieve, the FPF should also really facilitate the sit down with the team afterwards in one of sort of our standard models of communicating, bad news to patients in a quiet space, sitting at eye level, explaining, the steps that happen in the medical resuscitation because they might not have processed it at the time, and going through next steps and follow-ups with the family in a quieter sit down environment as well.
So as Dr. Sagalowsky mentioned, this is a really rapid-fire delivery of the curriculum, but wanted to just give you guys an overview. I actually just wanted to take a moment to touch on the parallel study that we're having where we're developing an observer tool that SPs and or outside observers fill out during simulated resuscitations about these observable behaviors. And that has really informed this curriculum and vice versa, and that's something that we're hoping to get out soon because, again, everything should be anchored in these observable behaviors as opposed to these internal thoughts that we can't necessarily discern from somebody during a resuscitation. So just briefly in summary, and I hope we have a minute or so for questions afterwards, it's very, very important to have a supported family presence during pediatric resuscitations. Many benefits for patients, family members, for the team alike. And then those key components as we went through: respect and value, information sharing, nonverbal communication, and summary and follow-up. And then just, a note at the end that this is a really difficult role emotionally, as all roles in resuscitations are, so it's really important to take care of yourself. So if everyone, again, we are right at 10:20 right now, we will take any questions, comments, personal experiences that you guys have, and then if you don't mind taking just a moment to fill out a brief survey, it really does help sort of inform our curriculum and the changes that it undergoes with every delivery. Yes?
So, I've unfortunately had this experience rather recently, and it's been a little raw, and I know that it is best practice, but you still, or at least we still, have these physicians where they're uncomfortable
Yeah, it's a really good question. I don't know if you want to turn on these mics as well to be able to answer. And I think that conversation really has to be explicit where you say, I've talked to the family member. This plays into the sort of dynamic positioning that we mentioned, where some family members will prefer to be outside for intubation, but saying, we've walked through kind of the steps, and the family member would prefer to be here at this time, and we can, reevaluate as the intubation progresses. But I think we all acknowledge that that's a really difficult sort of moment to hit, and difficult to navigate. I don't know.
Yeah, and I would argue that maybe the resuscitation space is not the place for that conversation with, thinking about change management theory and cultural acceptance of new ways to practice. It probably is going to take pre-work and, a lot of stakeholder input prior to that critical moment. And I think the other reality is that some people's likelihood of success for a critical procedure is much lower if they feel, the yips, right? Like you think about your second serve or my second serve in tennis, right? If there's a bunch of eyes on you, you might not perform as well. And so I would almost flip it and say to the family, we really want you here. This is a critical procedure. Would you be okay stepping out for a minute? And we'll step right back in after the procedure is terminated. And in the meantime, working with the providers on the culture change so that they feel psychological safety doing critical procedures, while the family is present.
Sorry, I wanted to say that with the insights through simulations that we're doing, all the faculty that is part of it or the fellows that are part of it are now used to the fact that we're going to have the family there. And they get used to doing the procedures with the family there. I think, as Dr. Sagalowsky was mentioning, that I think is what's going to help, or some similar didactic, change the culture.
Yeah, the actors make a big difference, the SPs, and just practicing with an SP in that role. Yeah.
Maybe you said it, I missed it. Your focus groups were with families?
So both family and youth advisory council members. So we spoke with teenagers who had experienced, hospitalizations, as well as families whose children had experienced, resuscitations, hospitalizations, and they were really crucial, in getting their perspective for the curriculum because, as we mentioned, many of these things are sort of EI, things that we do naturally, but especially things like the hand on the shoulder as providing support was something that we hadn't anticipated. And these focus groups were held in the middle of COVID, and still there was that overwhelming support for that practice. Yeah. All right, I think we are wrapping up at this point, but please feel free to reach out if you have any questions. And again, we welcome any feedback. Thank you, guys.